Bismillahirrahmanirrahim. It's a great honor for me to announce for the start of another webinar in the elegant Egyptian Indian online orthopedic course. We have many eminent stars from speaking from India, from Egypt, and tonight we have two eminent stars in the field of pediatric orthopedic, Professor Manoj Padman from India and Professor Mahmoud Elrosasy from Egypt. First of all, I would like to thank my dear friend, Dr. Sernivas Kamphamti for his great support and great effort to make this course live and to complete and finish the preparation of this course, and also the international trauma webinar that will be held on Friday, 25th of August, and more than 55 speakers from all over the world will be presenting in the this webinar. First of all, we will have an elegant presentation from Dr. Manoj Padman, and Professor Sernivas will have the honor to introduce our eminent speaker. Professor Sernivas, please.
Thank you, Professor Elrosasy, for the kind words, and it's been a pleasure and an honor for me to organize these talks. Today we have Dr. Manoj Padman, who is a good friend of mine. He is currently Director, Center of Pediatric Orthopedics and Disabilities in New Delhi. He's also the Director and Head of Pediatric Orthopedics at Rainbow Children's Hospital in New Delhi, as well as Director of Pediatric Orthopedics at Fortis Memorial Research Institute in Gurgaon near New Delhi. And he graduated and did post-graduation from JIPMER, Pondicherry in India. And I'm proud to say I graduated with him too. He then left to the UK and did a fellowship training there at Sheffield Children's Hospital. He's currently practicing as pediatric orthopedic surgeon at New Delhi for the last 14 years and successfully trained fellows in pediatric orthopedics. He's a regular member of national meetings in pediatric orthopedics in India. His interest includes all aspects of pediatric and adolescent orthopedics with special interest in pediatric hip pathologies, limb reconstruction, and deformity correction. Thank you, Manoj, for accepting the invite. You can share your presentation now.
Good evening, everyone. I hope my slides are visible. First of all, thank you, Professor Elrosasy and Srinivas for this wonderful initiative of collaborating between the Egyptian Orthopedic Association and Indian orthopedic surgeons. Clearly, it's an excellent initiative, and I'm privileged to be invited and taking part in this. So I'm going to spend this evening talking about a range of pathologies which affect the pediatric and adolescent bone and joint following osteoarticular infections. There is nothing more challenging than a neonate who has septic arthritis or osteomyelitis of the long bone, which then continues to kind of affect the child and pose a lot of challenges throughout the entire childhood, sometimes unsatisfactory outcomes despite optimal management. So I'm just going to kind of introduce a few case-based scenarios which kind of challenge the skills of us day in and day out. So when we look at osteoarticular infections, you can kind of look at problems emanating from the joint, or from the diaphyseal component of the long bone, or from the physis. And all of these, depending on what is affected, produce different set of challenges. So to give an example, I mean, this could be extrapolated to any joint, but classically, let's say the hip joint. When the hip is affected, you can have all grades of instability from dysplasia to dislocation to subtle instability, proximal frontal growth disturbances producing angular and torsional deformities, avascular necrosis, pseudoarthrosis, the neck is affected, stiffness and joint destruction. At the diaphysis, you can have pathological fractures and segmental bone loss. And if it is the physis which is affected, you can have growth arrest and all its sequelae. Now, another way of looking at it is in terms of sorry about that. Another way of looking at it from a management perspective is to address it at the different stages at which the infection presents to you. So I'm not going to talk about active infection, which is the management of the septicemic process, which requires prompt diagnosis, urgent intervention. So that's not the remit of my talk today. But as the infection gets controlled and then it goes through different stages, some of these consequences in the early stages are the challenge is actually to identify them, predict them, and to prevent them. And these complications, if one is aware, if one can prognosticate, then there is a good chance that, I'm not saying that it is 100% foolproof, but there is a good chance that sequelae can be minimized. If you miss this opportunity, or if it presents later, or sometimes due to the natural history of the illness, sequelae get established, then there is a phase wherein you can reconstruct the affected part so that full function can be restored. It may not be a single stage reconstruction, it may require multiple stages, but there is a good chance that you will be able to one will be able to achieve optimal function. Failing which, if you miss that opportunity, or if your initial interventions haven't been successful for whatever reason, then you're looking at a salvage option wherein the final outcome will almost inevitably end up in compromised functionality. There is a lot of focus on these two stages, but I'm going to spend the initial part of my talk focusing on identifying problems before they become well established, and to minimize the consequences of the sequelae as far as possible. So I'm going to throw up a few clinical scenarios. So why is this important? So here is a child who presented to my outpatients, a 7-month-old preterm, a fairly common scenario, I'm pretty sure, both in Egypt as well as in many parts of India. Neonatal septicemia, everything was treated well for the sepsis component, had a small abscess, which was not even, the orthopedic surgeon wasn't involved, but presented by 7 months already with a well-established deformity and shortening. And if one were to step back from this and just look at what are the future issues that are likely to be from this fairly innocuous presentation. The parents were quite happy that the child is thriving now, but they think, oh, it's a small deformity which is not going to cause much problems. But just step back and think logically in terms of what are the problems that the child can develop during entire childhood. It's a complex problem with a whole range of issues which one will have to tackle throughout entire childhood. Already the child has a deformity and limb length discrepancy. Once the child starts walking, he or she will have gait abnormality, limb instability, which will result in pain, stiffness, and loss of motion, either in its natural history or following any form of intervention, because it's very close to the joint. And inevitably, all of that can lead to functional limitation, postural problems, secondary compensatory problems, and even degenerative arthritis. Now, such a small problem happening in the proximal tibia at a very young age can have, it's almost inevitable that a lot of these consequences are going to happen. You may not be able to prevent it, but some of which, if they are identified and tackled at an early stage, you may be able to minimize it. Take, for instance, another 2.5-year-old who presented with following hematogenous osteomyelitis of the femur 2 years prior, presenting with segmental bone loss, with gross mobility at the pseudoarthrosis site. The knee is stiff. There is absolutely no movement at the knee. All movement is happening at the pseudoarthrosis. That's how the child presented. But if I were to kind of look back at the original X-ray, this is how it started 2 years prior. The infection was managed at some point due to the femur not being protected or due to lack of optimal management. This is how it ended us. And this is beyond salvage now. You know, whatever you're going to try and do is to kind of give some sort of a limb which can function rather than, you know, amputating it. So if I look at a few more clinical scenarios, so here is a 21-day-old baby, was late preterm, presented with to the pediatrician with respiratory distress, had Klebsiella septicemia, put on IV antibiotics, and the systemic features gradually settled. But subsequently down the line, they noticed swelling of the groin and thigh. A fairly routine presentation, but when it was referred to the orthopedic surgeon, there were no signs of active sepsis. Afebrile, normal vessel count. The CRP was coming down, but still slightly raised. So with no active, if you look at Kocher's criteria, pretty much all of them, the active infection is well under control, but there are some localized signs. And you look at the X-ray, you can see that the right femur is lateralized. Investigate this further because it's a baby. You rather than subjecting to an MRI, you can get an ultrasound and you can see clearly that the right hip is distended. There is effusion. The femoral head is lateralized. And on dynamic evaluation, you can see clear instability. Now, what are the issues here? The actual septic arthritis is almost under control because it's partially treated. There are some local signs, but there's no active infection. But the joint is subluxed. So what are your options? There is not much in literature given about partially treated joint infections. How do they pan out? There is plenty of literature about early pickups of septic arthritis, but late presenting partially treated infections, how do you manage? So what are your options? Do you ignore that? Do you aspirate and say, okay, if there is some pus, let me drain it out? Do you do an arthrotomy? How do you tackle the instability? I would urge you to not ignore this. You need to kind of, even though the sepsis act, there is no pus in the joint itself, it needs to be washed out. Protect the joint with a Pavlik harness. If the child is a little bit bigger, you can put a spica. Minimal hospital stay, continue the antibiotics for the infective process, but the joint has to be addressed. Joint has to be tackled. Follow-up scans clearly show that joint is well seated. That's 3 months later. It's not a perfect hip, but you can still see that the femoral ossific nucleus is starting to appear, which means there is no gross AVN. Further down the line, you can see that there's a lateralized head. This is much better than a dislocated head, than a completely destroyed head. You have something to work around with. And a lot of these cases, you need to follow them up to see how they evolve. You can see over time, nature is a wonderful healer. Once you create a correct environment, you can see how the hip is developing. And at 6 years of age, almost 5.5 years, almost 5.5 years after the original infection, you can clearly see that the hip is well developed, almost normal looking. So a timely intervention at an early stage, relocating the hip back in, has saved that hip, preventing sequelae. So that is something well within any surgeon's hand. Here is another case, similar subtle presentation, 4-month-old baby with a 3-day history of localizing problem in the right hip. There was an NICU stay, which is almost inevitable in all of these septic arthritis. They have in other systemic signs of sepsis for which antibiotics have been given for a long time. The acute signs of sepsis have completely settled. But there are local presentations. There is reduced spontaneous movement, there is pain on passive movement, rest of the limb is normal. And you can see on the X-ray that there is slight lateralization of the right femoral head. Again, none of the markers are conclusive for an active infection. Older child, so we could get an MRI done, which showed moderate effusion, and there is lateralization of the femoral head. So even though there are no acute signs, the hip is subluxed. The hip is clearly subluxed, and you can't ignore this because this is going to have a catastrophic outcome if ignored. We did an arthrotomy and washed out, seated the hip back in. The hip was quite stable, and because it was not a bacterial infection, the clinical pictures were very subtle. It was actually a fungal infection. And following them up, you can see that the hip is developing normally. Another common scenario, when pediatricians or neonatologists are not familiar with the presentations of sepsis. Here is again a 4-month-old baby, late preterm, similar pattern, NICU stay for about 10 days. Post NICU stay, reduced spontaneous movement of the left lower limb. You can see the classical position. The left hip is flexed, abducted, and externally rotated. Remotely, the child is from a remote location, was evaluated there. The treating orthopedic surgeon thought that there was a dislocation, but then went in a wrong direction, thinking that possibly it's DDH or a neurological problem. And you can clearly see that's the resting position. And you can see from the movement. And this is classical pseudo-paralysis. You can see the resting position and the pseudo-paralysis because there is some pain. There are no active signs of infection. For the child, if we do all the blood markers, they're all going to be normal. So that is clear pseudo-paralysis. In DDH, you never see this. This is pseudo-paralysis, always a consequence of some pain, which is trauma or infection. And again, you can see a simple X-ray shows that the femoral head is lateralized. And once again, not to be ignored, the hip needs to be located. The hip is not going to be perfectly normal because it's almost 3 months down the line. There is bound to be damage to the articular cartilage. And when we went in, we saw that there was erosion in the femoral capillary epiphysis. But it's better that the hip is seated in rather than left out. That's when the spica came out. You can see the hip is located. You can already see the erosion. But once it is located, there is a greater chance for the hip to develop near normally. I'm not saying it's going to be a perfectly normal hip. There are going to be issues, but it's better if the femoral head is located within the acetabulum, which gives you, as a treating surgeon, it gives you a lot more options to intervene further down the line. That's 6 months. That's the longest follow-up that I have of this child. He's continuing to be under my follow-up. You can see that the ossific nucleus capital epiphysis has not appeared yet. So there is bound to be some amount of avascular necrosis, but the metaphysis, proximal metaphysis is located correctly. So whatever is formed will be deformed, but located within the acetabulum. So the first take-home message from these cases is that subluxation or dislocation of the hip joint, one needs to have a high index of suspicion. Do not be fooled by the lack of active signs of sepsis, because sepsis would be partially treated. The clinical and lab parameters will be normal, and one cannot ignore it. It needs intervention. It is not to be ignored. Even subtle signs of subluxation or instability, the femoral head needs to be relocated with a formal arthrotomy. There is very minimal morbidity with an anterior approach arthrotomy and relocating the head at that stage. Now, if I continue on the same spectrum, moving away from the hip joint in terms of picking up problems early and recognizing the natural history of events. So here is a 5.5-year-old girl who presented with about just under 2 weeks history of progressively worsening pain localized to the left tibia. There was no preceding trauma. The referring hospital had picked up the infection in the leg, was advised surgical drainage, but the family decided to bring her over to the bigger city. You can see that these are the X-rays. You can already see, because it's almost 2 weeks down the line, you can see some amount of radiological changes, which is usually manifest only at about 2 weeks. Prior to that, X-rays are usually normal. There are clear laboratory and clinical findings consistent with active infection. The MRI showed extensive subperiosteal collections, circumferentially as well as length. Now, what is the implication of this? That's the thing. It's, yes, this needs to be drained. You need to have drill holes in the metaphysis to drain out the intraosseous abscess. You need to decompress the compartment. But such extensive subperiosteal abscess, what is the implication? So this was done. We drained. Within 7 days, the child's acute symptoms settled down. The leg was protected and plastered. That's a key thing, you know. Why does that matter? And this is something which I had the privilege of being part of a multi-author worldwide collaboration to write on pediatric osteoarticular infections. And the task that I had was to talk about pathological fractures along with Scott Rosenfeld and Mohan Beltur from the USA. And it's a fantastic book. I would urge those who are not aware of it to try and procure it some way, because it covers the full remit of infections. And as you can see from imaging, if you have an extensive subperiosteal abscess, which is a large circumferential size and involving more than 2/3, the risk of a pathological fracture is very, very high. Okay, so therefore, one cannot sit back feeling satisfied just draining the abscess. One has to protect the limb against fracture. So as you can see it's a pan-diaphyseal involvement, much more concentrated on the proximal metaphysis, but it involves the entire diaphysis. You can see as the disease evolves, that's 5 months post-surgery, still protected. Okay, but we had already had discussion with the family about potentially needing surgical intervention if the fracture did not heal, if nature did not control it. But as we continue follow-up, we were very pleasantly surprised to kind of see new bone forming. That's further down the line. And that's close to about 2 years post-surgery. The bone is by no means normal, but the fracture is healed. You can see there is abundant remodeling happening there. That's 3 years post-drainage. Nothing was done for the fracture. So the first step in terms of hematogenous osteomyelitis affecting the long bones is that recognition of risk factors which make the bone susceptible for pathological fractures, which can be from clinical, from microbiological, as well as imaging. And a substantial proportion of these cases, if the child is otherwise healthy with prolonged immobilization, nature itself takes care, the involucrum forms sufficiently and the sequestrum gets resolved. So you may not need to do anything. So you may not need to intervene, because intervention at a very early stage can have catastrophic sequelae, because you're disrupting the natural healing process. And unless you provide enough mechanical stability, it may end up as a pseudoarthrosis. So prolonged immobilization should be the first line of management for any scenario wherein you're anticipating a potential pathological fracture. So I'll illustrate the same example, what I mean by providing mechanical stability by showing this case, which is a 3-year-old who presented with, who had a history of cellulitis, osteomyelitis. Because in the tibia, sometimes a lot of these are treated as cellulitis, because tibia and the involvement of the bone is not appreciated. So there was drainage was delayed, and they presented 4 months later. That was the first time they presented to me, and this is what the child had. So you had an extensive sequestrum with loss of continuity of the tibial segment. But there are no active signs of infection. Inflammatory markers are normal, and the child had been on antibiotics for 2 months. More advanced imaging clearly shows the avascular segment. Now, long back, the traditional treatment was that the sequestrum should not be removed until the involucrum is adequate. Now, given if you can immobilize the child and protect the child for a substantial length of time, there is a possibility that an involucrum may form in this, but the chances are very small, because the extent of bone involvement is quite huge, and the associated morbidity of prolonged immobilization will not work. So if one has to kind of remove this focus of infection, but that would create a mechanically unstable environment. If you remove such a large segment of bone, that is going to create a mechanically unstable environment, which will not facilitate healing. So you have to think about how you're going to treat this. So yes, conservative and delay the intervention to see if involucrum is going to get formed. That's going to take a long time, and very likely it will not form. So if you go ahead with sequestrectomy and remove that piece, how are you going to stabilize it? Are you going to use internal fixation, external fixation, plaster? How are you going to manage the gap? Are you going to graft it, or are you going to transport? So all of these things come into the treatment planning. This is what I chose to do. We did a sequestrectomy, we removed it, we left the fibula intact, contralateral fibula was harvested and introduced as an intramedullary strut bridging the two ends of the tibia. So the rationale behind is that there is no active infection, so one can intervene. The unstable fracture, any delay is going to cause a lot of morbidity in terms of knee joint immobilization, adverse sequelae. The sequestrectomy allows us to clear out all the dead bone and focus of infection. Limited exposure, you don't have to do a radical debridement because there are no active signs of infection. So the posterolateral bed is left intact and the bone graft is put so that maintaining the stability. And you achieve further stability with a fixator. The fixator allows the child to be mobilized weight bearing. And that's what, prior to frame removal, that's how the bone looks like. Further down the line, you protect it in plaster when the fixator is out for about 6 weeks. And that's a year down the line. So the take-home message from this is that when you are dealing with an established sequestrum with a potential gap, then you have to think about, very often, a lot of the focus is on getting the biology right, which means clearing out the infection, putting bone graft and things like that. But mechanics is important. You need to get stability. Now, stability can be achieved even with plaster, but then you have to think about how long the plaster is going to be put and what are the consequences of that. So the mechanical environment, the mechanical stability is just as important as getting the biology right. So again, when sometimes things don't go as planned, so just to illustrate, because these are challenging cases, sometimes they do not follow a set course of action. So I don't want to leave people in the audience thinking that, you know, this is a very straightforward and a predictable course of action. So there's a 20-month-old. This I was involved in the care right from day one. So it's not something which I inherited from someone else. Tibial osteomyelitis and concomitant septic arthritis, again involving the entire segment of the bone, because right from the knee joint right up to the distal tibia, Staph aureus sepsis, arthrotomy drainage, acute infection well controlled. So you can see at 6 weeks, you can see at the distal diaphyseal and metaphyseal junction, you can see there is some disruption, but the involute from starting to form, that's 3 months down the line. The leg has been protected because there's a high chance of this ending up with a pathological fracture. However, unfortunately, at 6 months, despite adequate protection, you can see that there is a discontinuity at the proximal junction. Okay, so what are our options? One can wait and watch, again, giving it time for whether nature can form an involucrum around that, or you intervene. Because again, the segment of bone was, the gap was quite significant, and one felt that because the pan-diaphyseal osteomyelitis, the chance of inadequate involucrum formation in a reasonable amount of time is less. I chose to go ahead with an Elrosasy fixator stabilization and putting fibular graft, just as the similar case. Contralateral fibula was harvested without destabilizing the leg. Unfortunately, it did not heal up as well. You can see, although these were fine wires were used for fixation, you can see the hole, which means probably there was some low-grade infection around the pin site. So adequate stability was probably not achieved. So no shank pins were used, but you can see the pinhole is fairly big. And you can see that the continuity is not adequate. And not surprisingly, 12 months after surgery, you're left with a better quality of bone overall, but with a gap, with no continuity there, with no active signs of infection. So one again goes through the various treatment options. Are we going to redo a graft? Are we considering a transport? Do we opt for internal fixation, or vascularized fibular graft, or we wait and watch? So one has to kind of weigh the pros and cons of all of it. Because I've had reasonable success with my Elrosasy and fibular grafting, I chose to go ahead and do it all over again. This time around, unfortunately, the fixator had to be removed a little prematurely before the bone could consolidate, because the child had a fall and broke his femur. The child was quite mobile and quite an active child. The fixator frame wasn't bothering him, and he presented with this acute pain. So we had to remove it to manage the fracture. And lo and behold, again, you create an unstable construct. So this is not satisfactory. This is after revision surgery. So this is where it ended up as 2 years post-acute infection, 1.5 years post-index reconstruction, and 6 months post the revision. So I've already kind of burned my bridge with fibula grafting twice, so I'm not going to do that again. So what are my options? There's not enough bone to do a bone transport. Do I do an internal fixation and bone graft it? Do I consider vascularized fibula graft? But the good thing about this is while as a treating surgeon, one may end up being depressed by these outcomes, you can see that there is growth happening at both ends. So whatever one has is, while one is contemplating in the optimal management, you should not, end up damaging the field in which you're working. So both the proximal and the distal tibial metaphysis is growing. You can see growth arrest lines there, and they're continuing to grow. But at the pseudoarthrosis site, there is no satisfactory outcome. So we thought long and hard, and some of the things that then you need to get appropriate counseling, second opinions as needed. You need to talk to plastic surgeons about potential of vascularized graft, but unfortunately, both the fibula had been harvested, so that wouldn't be an option. So interestingly, I saw that the fibula was coming in proximity to the tibia at the distal site, and this was where the problem was. But distally, you could see there's almost like a synostosis. So if I could do a pictorial illustration of what's happening, so that's where the problem area is. And here there is some union happening. Although on the lateral view, the proximity of the tibia and the fibula is not that apparent. So we thought maybe creating a synostosis and creating a rectangular strut of bone to stabilize it would help. The plate was slid in along the subcutaneous border. The bone went on to unite, and the child was actually weight bearing without any plaster initially, but he presented with subcutaneous infection in the subcutaneous plane, unfortunately. But the synostosis had already been created, and the plate could be removed. So this is the best that the child had been in nearly 2.5 years since the original infection. So again, when you look at it, both the proximal tibia and the distal tibia is continuing to grow. The fibula station is at normal levels. There is no limb length discrepancy. The joints are moving well. So despite a circuitous route and despite multiple interventions, there has been no catastrophic consequences. And sometimes that is an important thing to bear in mind. So any planned intervention, you need to remember that you have to preserve the existing function. If in the process of trying to achieve union, you lose knee function, the knee becomes stiff, or there is growth plate damage, and you have other problems to deal with, then that becomes a more challenging scenario. And one always has to factor in need for future surgeries in these kind of cases. So the first, I think I have probably about another 10-15 minutes. Am I right? So if I move on to the next phase of sequelae, wherein one is talking about what are the reconstructible options, what are the scenarios wherein one has missed the preventable and predictable consequences. So I'm not going to cover the salvage options. I think there is an eminent speaker after me who is probably going to talk about those scenarios wherein there is soft tissue and bone loss. So here is a situation. Acute osteomyelitis, unfortunately, I do not have the original pictures. Had fracture through the drill holes, femur, notorious for having pathological fractures, so one has to protect it. Underwent elastic nailing, which was revised by the treating surgeon to plate with bone graft, and kept the child for non-weight bearing for 6 months. But the fracture never united, and this is how the child presented 1 year post-plating. With a stiff knee, with a leg length discrepancy. The shortening is difficult to measure with a stiff knee. It was quite difficult to kind of measure the exact degree of shortening. So what are our options here? The implant has to come out. That's not doing anything. So one has to excise the avascular segment. What then after that? Post-excision, if you break it, the management into different components, how are you going to achieve stability? Internal fixation, external fixation, plaster. What about the gap which is going to be there? Are you going to graft it? Are you going to transport bone? Length management, is that to be tackled now, or is it something which has to be tackled later? What about the joint stiffness? Now, Elizara is a wonderful tool which can probably address a lot of these things, but then one has to bear in mind that it's going to be a big incision to get the plate out, and afterwards putting a frame over it has its own risks. So are you going to stage it? So these are the questions that come into the mind. It would be wonderful if this would have been ideal for an interactive discussion, because I'm pretty sure there'll be different views on this, different ways of managing it. I'm pretty sure there are people in the panelists and the faculty as well as in the audience who have probably experience in managing these kind of scenarios. So this is what we found when we went in, that the nature of the soft tissue, the quality of metallosis, the quality of the bone, the two intramedullary rods are pins are just showing what is the status of the bone and at the pseudoarthrosis site. So we excised this is what I chose to do, excise the segment, kept an intramedullary rationale, and I thought this would be a good case for a masculine induced membrane technique. Not much has been written up in the pediatric literature with the masculine technique, which is well established in adult situations, both in trauma and infection. Pediatric literature, there isn't a lot published, and most of it is post-tumor treatment. So cement spacer was put, an intramedullary rush nail. The child was protected in a long leg plaster, and 6 weeks down the line went on to have the second stage, wherein the membrane is preserved, bone graft is harvested from the iliac crest, and a bridging plate. That's how the child was further down the line, starting to weight bear and mobilize. So that's him just under a year. You can see that by the way the rush nail has migrated, that the distal femur is growing. There's bridging callus across the pseudoarthrosis site. The limb alignment axis is maintained. The range of movement has improved because now we have a stable femur. The leg length discrepancy was now subsequently measured, came down much lesser to 4.5, well compensated with an inch shoeraise, and the family chose to delay their intervention for limb length correction, which could be most likely a contralateral epiphysiodesis at the right time. Because lengthening this has its own challenges. So the take-home message here is that when you have scenarios which pose multiple challenges, break it down into components and choose one battle at a time. If you want a single strategy to tackle length difference as well as to achieve union, sometimes it may not work out. Achieve union, get the joint moving, create a good biological environment before you tackle length. Length can be tackled much later. So you may have to think about out-of-the-box solutions. Here is a 4-year-old presented with a limp from the time he started walking. He had neonatal sepsis, which had been operated twice before the age of 1 year. There's no active signs of sepsis, and this is how he presented. So this is well past the stage of preventing anything, is established consequences. This hip is not going to be normal no matter what you do. So you're playing catch up. This is close to salvage option. You can reconstruct quite a lot, but it's never going to be a normal hip. So this is when he presented at 4 years with consequent acetabular dysplasia. The femoral head is small. There is absolutely no telescopy. The pseudoarthrosis is actually a stiff pseudoarthrosis. Leg length discrepancy about 4.5 centimeters. It took an MRI to establish the status of the femoral head. The femoral head signal, the radiologist reported that it's comparable to the opposite side, which means it's not completely avascular, and therefore made sense to preserve it. So this would be my classification. It showed type 3B septic sequelae, which produces pseudoarthrosis. So again, break it down into components. What are the problems that need tackling? We need to address the mechanical instability, the head shaft discontinuity. questionable viability of the hip, high riding trochanter, which is producing a functional coxamara with abductor insufficiency, secondary acetabular changes dysplasia, which will have a bearing further down the line, and limb-length discrepancy, which is what exists now as well as future. So if you think of solutions you could do a bone graft and fibular strut and create stability there. What about the viability of the head? Multiple exposures already, how are you going to fix it? So the high riding trochanter can be brought down by a valgus osteotomy, acetabular dysplasia with a pelvic osteotomy, and that has to be addressed for future lengthening. If you have to lengthen, you need to have a stable pelvis with a deep acetabulum. And the actual planning involves factoring in the previous surgical scars. What implants are you going to use? Are you going to use internal fixation, KYS? And what is the role of spica? So this is what we chose to do. We did a subtrochanteric valgus osteotomy. You can see that the orange mark is where the head is. So that's where the head position is. The pink is the lesser trochanter, and the yellow is where the greater trochanter has been brought down with a valgus osteotomy, which is with an end-to-side apposition fixed with a synthus plate, a valgus plate, 140-degree pediatric plate, and a fibular strut across the pseudoarthrosis. Fairly stable construct, but nevertheless, I chose to protect it in spica. I always do an arthrogram in this to assess what the hip is. So hip is sitting very well because valgus can uncover the femoral head. There is already concomitant acetabular dysplasia, which would have a bearing for any femoral lengthening, and therefore I did a Dega osteoplasty at the same time. Protected in spica, even though the osteotomy was quite stable. That's when the child started weight bearing. He went on to have a femoral shaft fracture below the plate following a fall. Fortunately, that went on to heal without any operative intervention. He came back about 16 months down the line, and with a few concerns here. You can see that at the pseudoarthrosis site there is not enough callus as you would expect. The head size is still looking small. The Dega osteotomy has healed well. So I was concerned about what is happening across the pseudoarthrosis site. The CT scan confirmed my worst fears about a gap. The screw looks loose. So what do you do now? So we exchange the screws to longer screws to get right up to the subchondral bone. There was enough gap proximally to reinsert. There's nothing else which can be done. We put an additional fibula across. And that's how he presented recently for implant removal, 2.5 years after index reconstruction, 15 months post-revision, with a limb-length discrepancy much lesser than what it was, the valgus gain in length. And you think, oh, everything is fine, this is great. Whenever I take a child for anything under anesthesia, I would always do a dynamic evaluation. An arthrogram looks at the nice head, large head, but sitting well. After post-implant removal, you can see that the hip is seated well. It's a coxa magna, it's a bilobe type of head. But the worrying bit was as you adduct it, you can see that the hip is starting to come out. That's the outline of the femoral head in yellow, and that's the acetabulum. So the large head is, despite the Dega, is still unstable there. This will have a bearing if you choose to lengthen the femur. It will definitely have a bearing when you're lengthening the femur. The hip is going to come out. Even otherwise, this may have problems as the child grows into an adolescent. So it has thrown up a new challenge, even though the initial evaluation looked that we had achieved a very satisfactory outcome. So the take-home message here is that this is not a sprint, even though the child, this is a marathon. This is not a 100-meter race. Think long-term, anticipate future problems. The lengthening will happen probably 5-6 years down the line. So if that acetabular dysplasia is not addressed, that hip is not going to withstand any lengthening. So we now have more powerful tools to address some of the hip problems. This is again an adolescent who had a neonatal septic arthritis, but the child was asymptomatic until he reached his teenage years and presented with a 1-year history of limb, but had significant findings. You can see what the sagging rope sign, which is the anterior femoral head, the cam part of the anterior femoral head, gross torsional abnormality with femoroacetabular impingement because of the anterior bone bump. safe surgical dislocation to reconstruct the hip and to tackle all the problems is a very powerful tool, can address all the problems. You can remove the anterior bump. You can do a relative neck lengthening by creating an extended flap and address the torsional profile as well. Correct the caput valgum with a varus derotation osteotomy. Restore the biomechanics, correct the version, get stable alignment of the hip, correct the coxa vara. So all of that is taken care of with a powerful surgical tool. Now that we know the femoral head vascular anatomy a lot better, thanks to the pioneering work from Byrne. So follow up, you can see that the rotations have been symmetrically restored. Leg length discrepancy is still there. So the implants were removed and contralateral distal femoral epiphysiodesis has been done. So again, one cannot have a single tool to correct the hip biomechanics as well as length. So it may be better to leave the length aside to be tackled in a different way. A contralateral epiphysiodesis done at the right time is low morbidity, while the hip is optimally positioned. Hip biomechanics optimization is a very powerful tool, and it works well for long-term hip preservation. I just wanted to know from this thing, I think I've reached my time. I've got another case, but I am happy to kind of take questions or anything at this stage if you think that. Can you hear me?
Yes, sir, we can hear you. Dr. Srinivas, any questions to our dear Prof?
Thank you very much, Manoj, for the very interesting cases. They are very challenging and interesting and quite rare as well. Some of the cases you presented are quite rare. I think there is one question somebody had asked. It's from Dr. Mudaffar. They're asking whether you do all in the same session, sequestrectomy, fibula graft, and Elizaro in the same session?
If there are no active signs of infection, when it's burnt out sepsis, there is nothing which kind of precludes grafting that area. I would go ahead and do it in the same sitting, because this is not a radical debridement to remove the pus or anything like that. The pus and tissue is all burnt out there. It's scar tissue, it's dead tissue. So you can debride it, create a viable bed. You can put the fibula strut, and the Elizaro fixator adds to the stability. So all of it is done in one sitting.
And you presented the case on pan-diaphyseal tibial infection, where one of the important messages you said was protect the limb in a cast. How long would you protect the limb in a cast? Because infection in a bone seems to, tends to persist for a long time.
Yeah. So how long, there is no clear answer. And so whatever appropriate and ideal has been, if whatever appropriate and ideal has been done to eradicate the infection and you're on top of the acute infective process, that's well on its way to control. So the child is off antibiotics, the markers are normal. So there is plenty of evidence that prolonged immobilization can allow it to heal. I do have, apart from these cases, I do have at least another 4 or 5 cases, both in the upper limb and lower limb, in whom I have discussed surgery, and the family are like gradually coming around. It's taken 2 months, 3 months, 4 months, 6 months. And then finally they say, okay, and then you're following up X-ray, suddenly you find that the humerus is united. There is bridging callus. So prolonged immobilization, so long as it's not going to kind of jeopardize the adjoining joints, I don't think has a problem, because the alternative of reconstructive surgery is fairly complex, because it will involve grafting, fixation, stabilization. So that's a huge thing, and sometimes it may not work out. So, so I do not have a timeline, but there is plenty of evidence. I can speak of my own practice as well as out in the literature that prolonged immobilization can. And that, if you go back, Srinivas, is the dictum which was like 50 years ago, 60 years ago, prior to all of this. They would say, oh, wait until the involucrum forms, because at that time, if you put somebody in a spica for 6 months, 1 year, 2 years, probably bone is getting formed. And, but then there is collateral damage, collateral morbidity of joint stiffness and things like that. So for a tibia, I would quickly convert it to a PTB type cast so that the knee is kept mobilized and things like that. So long as there is no collateral damage, then I think it's fine.
And it's interesting to see a masculine technique being used in infection in children.
Yeah.
I was going to ask you about that actually, but so you presented a case on that. When do you decide to transport versus graft with an Elizaro?
I am biased more towards grafting than transport because when a lot of these extensive bone infection, one does not know what is the quality of the bone further down the line. I have burnt my fingers in the past transporting and then having new problems at the transport site. The original pseudoarthrosis heals and then I have had problems there. But that I'm pretty sure there is enough experience. There are more skilled surgeons who are able to kind of get the same outcome with transport. I do not have a clear answer, but I am more biased towards grafting rather than transport.
What about antibiotic beads? Use of antibiotic beads in controlling infection?
Yeah, so controlling infection, that's a different thing. I don't think I've touched upon that at all. So if there is active infection or if there is some amount of infection there, then all these measures come into the picture. Purely just antibiotic beads alone, because I do have cases. I think I've not treated it yet. I showed the case of the femoral osteomyelitis, which started off with an intact bone, and within 2 years, the entire bone has disappeared. So what the caution that I would have is if there is active infection, yes, by all means, that needs to be treated. But sometimes one sees changes on images, which kind of suggest the radiologist would report that there is ongoing infection. And during that critical phase, when the body is trying to kind of control it and form involucrum, aggressive debridement is dangerous. Aggressive debridement, if it's needed for drainage of pus and things like that, but sometimes the signal changes and things like that, the soft tissue edema is interpreted as active infection, and the child is otherwise well and the bloods are well. So in fact, aggressive intervention at that stage to get local antibiotic delivery, local bone grafting, without kind of factoring in the natural healing process, I see that creates a lot more problem, because antibiotic delivery alone is not the problem there. You need to have a good viable bed, and you need to have mechanical stability.
We have 2 more questions, I think, from the delegates. One is from Dr. Khalid Yusuf. Does coxa magna need to be treated?
So that's a difficult one. So the difficulty is if the hip is contained, if the acetabulum is reciprocally large, then it does not need to be treated. But if there is coxa magna and there is subtle instability, then that's not good news. If the coxa magna, a lot of these post-septic end up having coxa magna and sometimes coxa bilobed femoral head, coxa irregularis. And if there is instability, like the child I showed, he has coxa magna and there is irregular, and that will cause problems. But if the coxa magna is reciprocally fitting into the acetabulum, then it does not require treatment. Equally, treatment of coxa magna is not easy also, because you do not know how to get the acetabulum around it.
So another question was, any specific strategy after resection and results of culture revealed resistance to all antibiotics?
So I think what I want to kind of illustrate is wherever I'm talking about resection, there is no active infection. Almost inevitably, they've been hit hard with all kinds of antibiotics, that there is nothing growing there. If there is active infection, then definitely, that needs to be controlled, because all your outcome is going to fail. But most of the cases wherein I have gone in, and it's like a few months down the line, it's all burnt out sepsis. There is absolutely no chance of getting any infection as such. The infection is not so much the problem. That's burnt out. It's in the process, the bed is devitalized, devoid of blood supply because of the consequences of infection or the surgical intervention. And that's the bigger problem.
Okay. Thank you very much.
Dr. Srinivas, we have another question from one of our attendees.
Oh, okay. From Dr. Muhammad Osman. I'm not sure what the question is, but it says Pseudomonas was the species. Probably how would you treat?
How do you, yeah.
So I do not know whether anything specific has to be done differently for Pseudomonas as such. I don't remember. The only thing is that comes in along with the gram-negative organisms. So we don't encounter it commonly. I think I had one child who had bilateral Pseudomonas infection, who presented with a grossly deformed femoral head, but sitting within the acetabulum. I'm unaware of Pseudomonas specifically causing any different type of problem as such.
Yes,
that's great. Thank you.
Most of the risk factors in terms of a bad prognosis with pathological fractures or recurrent infections or systemic complications are related to Staph aureus. So Staph aureus, MRSA, and different other virulent organisms. There's a lot of research there happening. I'm unaware of anything specific related to Pseudomonas.
Yes. Any other questions, Dr. Srinivas?
No, sir. Thank you very much.
Thank you
Thanks
so much.
a lot.
Thank you so much, Professor Manoj, for this very interesting presentation, and thank you for accepting our invitation, sir. Thank you so much, sir. It was an honor.
Thank you for having me. Thank you.
Thank you, sir. Now we will move to the next speaker. Our next speaker will be Professor Mahmoud Elrosasy from Tanta Faculty of Medicine. Professor Elrosasy is highly specialized and one of the eminent stars in pediatric orthopedic. He's one of the administrative board of the Egyptian Orthopedic Association, and he has taken a fellowship in pediatric orthopedic from Baltimore. Professor Mahmoud.
Thank you, Dr. Ashab, for your nice introduction. And I would like to thank Dr. Manoj for his interesting talk. He covered the aspect of the hematogenous osteomalacia very nicely. And I would like to stress on the point that hematogenous osteomalacia is totally different from post-operative or post-traumatic osteomalacia. In terms of the organism, the pathogenesis, and consequently the prognosis and the approach and the management. He covered the topic very nicely. And now I will talk about the counterpart, osteomalacia post-traumatic and post-operative in adults. Please allow me to share my screen. This post-infection sequelae. Okay. Can you see my screen?
Yes, sir.
Okay, thank you. This is Mahmoud Elrosasy, Professor of Orthopedic Surgery. I am the Chief of Limb Lengthening and Reconstruction and Pediatric Orthopedics, Tanta University, Faculty of Medicine. I will be talking about the post-infection sequelae, the management of composite bone and the soft tissue loss. Infection, deep infection is the worst prognostic factor in fracture management, and even in orthopedic as a whole. It carries the worst prognosis. It is a group of conditions, indicating the presence of bacteria, which starts or ignites an inflammatory response, causing progressive bone destruction of bone with suppurative process. The infection may be obvious with open draining wounds, erythema, and inadequate soft tissue coverage, or maybe subclinical. So the orthopedic surgeon or treating surgeon should have a high incidence, high suspicion index, especially with increased elevated ESR or CRP, which may indicate infection. Infection or osteomyelitis is a surgical condition, the primary management of which is debridement. This is in contrast to the hematogenous osteomyelitis, where the treating surgeon and the patient's caregiver should have a lot of patience before deciding the debridement. Here in post-traumatic or post-operative infection or osteomyelitis, debridement is the mainstay of treatment. Multiple cultures are necessary to detect the infectious organism. The classification of post-traumatic or post-operative adult osteomyelitis is difficult, and the literature research revealed more than 13 classification systems. However, all of them shared 7 different variables, are basic in almost all classifications. They included the bone involvement, acute versus chronic infection, the etiopathogenesis of the condition, the status of the host, whether in good health or in bad health, the soft tissue condition, microbiology or the organism of infection, and location of the infected bone. As we said before, the treatment of osteomyelitis is debridement. It is a surgical condition. However, we run a fine line between the aggressive debridement. The treating surgeon is willing to remove as much infected tissue as he can. However, this will result in extensive bone and the soft tissue defect, and hence will make the reconstruction or subsequent reconstruction much more difficult. Another problem is that every case is unique and has a different scenario. As we see in these different images, every case is totally different from the other one. So the reconstructive approach can be based on 2 main determinants. The first is a problem list, the identity or the characteristics of the infection in terms of the host type, whether it's the host type A or B or C, where host A is healthy, in good health. The type B, he has a medical problem which can be corrected. And type C, he has a medical condition where surgical interference is much worse than leaving the patient without surgical interference. The bone stability, whether we have a consolidated bone or we have a well-fixed fracture. On the other part, if we have unstable fracture or unstable bone with bone loss, the presence of bone infection, the bone defect size, a small size defect with infection is totally different from a big sized bone defect with infection. The integrity of the soft tissue envelope is very important also. Acute versus late presenting cases. The other main determinant is a surgeon's experience and training, where the Elizarov trained surgeon is totally different, has a totally different approach from the microsurgeon. So the surgeon's training and experience play an important part in the choice of the treatment approach. Based on this, we have 4 different reconstructive approaches for post-traumatic osteomyelitis. The first is distraction histogenesis based on the Elizarov technique mainly, or external fixation techniques, the orthoplastic techniques, the masculine technique, or a combination of all 2 or more of these approaches. Another problem in the management of post-traumatic osteomyelitis is a lack of clear guideline regarding the most suitable treatment for every case scenario in terms of description and classification, how to classify every case, and consequently, what is the best algorithm for management. And the other factor is the prognosis and the outcome measurement to compare the results of different approaches. We based our classification and algorithm of management on 4 important factors. The first is the stability of the host bone, whether we have a consolidated bone or a well-fixed fracture versus unstable fracture. The other factor is the infection of the host bone, the presence of deep infection. A third factor is the size of the bone defect. And the fourth factor is the contamination of the medullary cavity, because if we have localized infection at the fracture site, this is much easier than having deep infection contaminating the whole medulla of the bone, like in cases of infected intramedullary nail. We published this classification 2 years ago in the Journal of Injury, and I will summarize this. Our classification of traumatic composite bone and soft tissue loss, we divide the post-traumatic composite bone and soft tissue loss into two types, type A and type B. In type A, we have a stable host bone or a well-fixed fracture plus soft tissue loss. This is subdivided into subtypes A1 and A2. Type A1 without deep infection, type A2 with deep infection. Type B, we have unstable fracture or bone loss plus soft tissue loss, and this is subdivided into two subtypes. Subtype B1 without deep infection, subtype B2 with deep infection. The cases without deep infection are further divided into three groups. Group 1, the bone defect is less than 3 centimeters. Group 2, the bone defect is 3 to 6 centimeters. Group 3, the bone defect is more than 6 centimeters. Subtype B2, there is deep infection. Divided into group A, no medullary contamination. Group 2, we have medullary contamination. Consequently, we have 7 types. With the least affected type is A1, there is a well-fixed or consolidated bone with soft tissue loss and no deep infection. The worst case scenario is B22. There is unstable bone or non-united fracture with bone loss. There is medullary contamination and there is soft tissue loss. And hence we designed our algorithm and decision making for management of such cases. This is based on the debridement of the deep infection. In type A1, there is no deep infection zone and we fixed or stable bone, host bone, so we go directly for soft tissue reconstruction. In subtype A2, there is deep infection, but we do debridement. If the host bone remains stable, so it is downgraded into type A1, we go for soft tissue reconstruction only. If the bone became unstable or lost stability, so it is upgraded into subtype B1, where there is no deep infection and unstable host bone. So based on the bone defect size, if the defect is less than 3 centimeters, we can go for acute shortening, bone grafting, and fixation, whether external or internal fixation. In group 2, the bone defect is 3 to 6 centimeters, so it's best treated by acute shortening and re-lengthening or bone transport plus or minus bone graft and external fixed. Group 3, the bone defect is more than 6 centimeters. This is best treated by bone transport or vascularized fibril graft. This according to the surgeon's choice and discussion with the patient. The worst case scenario is subtype B2, where there is deep infection. In group 1, there is no contamination of the medullary cavity. So we go for debridement and bone transport. For group 2, there is contamination of the medullary cavity. This is best treated in a staged manner by a combined approach. Either Masculé Elizarov technique, we do Masculé at the first stage and then Elizarov bone transport, or Masculé orthoplastic. We go do first stage Masculé until we decontaminate the bed and then do vascularized fibular bone graft. Implementation of the classification. The classification is useless without being applicable and can be implemented in real life. We have this case, type A1, stable host bone, the fracture is united, but there is soft tissue loss and no deep infection. So we go for shaving of the exposed bone and the soft tissue coverage using local flap. This is type A2, stable host bone with deep infection. So we went for removal of the implant, shaving of the infected bone, and application of negative pressure wound therapy, and the wound healed without any further interference. Type B1, this is unstable host bone, no deep infection, and the bone defect is less than 3 centimeters. The treatment was acute shortening, iliac crest bone graft, and hybrid fixation due to osteoporotic bone. Type B1-2, unstable host bone, no deep infection. The bone defect is 3 to 6 centimeters. So the treatment was resection, square osteotomy, resection of the exposed bone, because according to Elizarov, a bone losing more than 50% of soft tissue or perosteal coverage is a dead bone. And it does not make any sense to try to heal or unite a dead bone. So we do square osteotomy, as we will explain later on. And we did bone transport from proximal, because the defect was about 6 centimeters. We cannot go for acute shortening. And we can see the open fracture, and the composite bone and soft tissue loss has healed completely without any bone or soft tissue grafting or flaps. This is a type B21, unstable host bone. There is deep infection and no medullary contamination. The infection is localized to the fracture site. So the treatment was debridement, acute resection of the infected contaminated bone, and the unhealthy skin. We did acute shortening and proximal re-lengthening. Type B22, unstable host bone with deep infection and medullary contamination. This is an infected nail. So the whole medullary cavity is contaminated. If you apply external fixator at this time, then the pin site infection will disseminate in the whole bone. So we go for staged reconstruction by debridement and overreaming to remove the bone sequestry from the medullary cavity. Cement spacer, we do Masculé Elizarov technique. I will explain this in detail in the following cases, slides. This is the worst case scenario B22, unstable host bone with deep infection, medullary contamination. We did staged reconstruction. First stage is debridement, insertion of antibiotic cement spacer, and the case was downgraded to B13, unstable host bone, no deep infection, bone defect more than 10 centimeters. In such cases, we prefer pedicle or vascularized fibular graft. Our approach is based on destruction histogenesis. Destruction histogenesis has proven to increase the blood flow and the perfusion distally in the limb, which helps to fight infection. This is based on the tension stress effect. When the tissues are subjected to destruction, this will lead to hypertrophy of the cells and then multiplication of the cells and the new cell formation. So this is the rule of the tension stress effect on which is based the Elizarov or external fixation techniques. Bone tissue is unique in that when it is distracted, it regenerates by new tissues which are identical, histologically identical to the native tissues. This is in contrary to any other tissue. So this is very important in the factor in the destruction histogenesis. We can see here in this case, this is a very nice demonstration of the destruction histogenesis. And the right side slide, we can see here, the right side picture, we can see a case of infected open fracture of the distal tibia with skin loss. We did debridement and the remove excision of the exposed bone, and we did proximal osteotomy for the proximal to distal transport. On the left side picture, we can see complete healing of the soft tissue, eradication of the bad infection, and the consolidation of the docking site and the proximal osteotomy without any bone or soft tissue grafting here. So if we try to define what is a bone transport, bone transport is not just transport of a bone segment. It is an advancement of a local vascularized osteomyocutaneous flap, the bone segment and its overlying bone, muscles, the subcutaneous tissues, and the skin. So it is a osteomyocutaneous flap which is transported to bridge bone and or soft tissue defect, either gradual or acute, using the destruction histogenesis and external fixation techniques. This procedure can be performed gradually in the traditional Elizarov techniques, where we do debridement of infected and dead tissues, metaphyseal osteotomy, bone transport. Then we go for management of the docking site and wait for bone consolidation, like in this graph. In figure A, we can see an open infected fracture with exposed bone. In figure B, we do debridement, square osteotomy, excision of all infected tissues. Then we do proximal osteotomy, and then gradual transport from proximal to distal. This case for demonstration, this is a 32 years old male who had an open pilon fracture treated in this way. And when he came to us, was in this picture, and he was advised below-knee amputation because of compromised circulation, deep infection, and extensive bone and soft tissue loss. We went for debridement, modest shortening to improve the bone coverage, and we did proximal osteotomy, and we left a gap about 9.5 centimeters of bone loss. This application of the Elizarov external fixer during the treatment. We did proximal to distal. You can see here improvement of the soft tissue condition. We were planning to do a split thickness skin graft, and to our surprise, we can see here complete epithelialization of this extensive skin loss without any interference for skin grafting. You can see the power of destruction histogenesis. Proximal tibial transport about 9.5 centimeters, consolidation of the distal docking site, tibio-talar fusion, and the complete healing of the soft tissue loss and eradication of the infection. And the patient, this is a functional outcome. The patient came back to his job as a trailer driver. However, bone transport is not without problems or difficulties. The problems reside mainly during the phases of bone transport and the management of docking site, where during transport, the transport segment can be deflected and it takes a different path. Then we have to go back and at the end of docking and improve the docking site and correct the path of the transported segment. Another problem is the insinuation of the skin or invagination of the skin between the bone ends, where we have to go and excise excess skin and adapt the skin edges and the docking site. We may insert iliac crest bone graft. For this, we adopted acute shortening and re-lengthening technique with the idea of minimizing the complications of the treatment and to shorten the treatment time, where we do the debridement in the regular way, and then acute shortening to close the defect and do the docking acutely. Then we have a short but straight bone. Then we do a proximal osteotomy or distal according to the longer bone segment for re-lengthening. However, we convert a complicated limb reconstruction into a relatively simpler limb lengthening procedure. But you have to be aware of ischemia. Don't do acute shortening and the next day do amputation. You have to do acute shortening within the safe limit. The safe limit for the proximal leg is about 3 centimeters. In the middle of the leg, about a little more than 3 centimeters. In the distal leg, we did up to 5 centimeters. In the femur or the thigh, you can shorten about 5 centimeters. But you have to watch for the distal blood flow. If there is any doubt about the patency of the distal blood flow, you have to re-lengthen open the acute shortening and go for gradual bone transport, which is much safer. This is a demonstration case of the technique of acute shortening. There is a bone defect and leg shortening, and we did the skin incision. The best for acute shortening is a Z incision to allow a widening of the soft tissue tunnel for acute shortening. And we then do proximal osteotomy for re-lengthening. Very nicely healed proximally and distally, and no problem with the skin healing. This is a case we showed before. the infected plate of the tibia with non-union. There is a sinus draining pus and the back's local soft tissue condition. So we went doing a Z-shaped skin incision with the horizontal limb elliptical in shape to excise the unhealthy skin and the soft tissue. Like the excision of a tumor, we do the oncological debridement. We remove all infected tissues, including bone and all metalwork, and then proximal osteotomy for re-lengthening. We can see very nice healing of the osteotomy length proximal and the docking site without any bone graft or skin graft with complete eradication of infection. So what about badly infected fractures with medullary contamination? In such cases, we prefer the staged reconstruction. And we developed our integrated protocol for management of post-traumatic osteomyelitis of the tibia. We treat post-traumatic osteomyelitis like treatment of the tumors. We go through for 3 phases. The first phase is the debridement. The second phase is the management of the dead space. The third phase is the reconstruction of the bone and the soft tissue. The debridement you should go through a safety margin of at least 5 millimeters, because intralesional curettage only of infection, there is 100% recurrence rate of infection, according to Simpson, his very interesting article about the safety margin in debridement of the infection. Because actually, we have, if we have infected non-union, for example, in the tibia, so the red zone is the infected zone. The yellow zone is a transition zone. It is a potentially infected. And the green zone is a healthy zone. So you are actually doing your debridement through the transition zone. Where there is, after your debridement, there is an infected transsudate. That's why you cannot go directly for reconstruction after the debridement of badly infected cases, because you are actually not removing, you are doing debridement, macroscopic debridement of microscopic structures. What are the keys for adequate debridement? It is an oncological debridement. Oncological means removal of all infected tissues or provisionally infected tissues with a safety margin of about 5 millimeters at least, square osteotomy of bone ends. So when you do transport or acute shortening, you have good bone contact, wide bone ends to allow healing. And the cases where we did the square osteotomy, most of them healed without bone grafting. Soft tissue curtain is very important. You have to do your bone resection shorter than the soft tissue. So you don't leave any exposed bone. The soft tissue should be hanging and covering the bone ends. In the phase 2, the management of the dead space. If you did your debridement and leave a dead space, this dead space will be filled with hematoma and the infected transsudate with recurrence of infection. Another problem is that this dead space will be obliterated by fibrous tissue, making any grafting or bone transport very difficult. So never leave a dead space. Either close the dead space by acute shortening or by a cement spacer, or the open technique, or fill it with a cement spacer, even if you cannot close the skin, and apply a negative pressure wound therapy. And I will demonstrate this. The third phase is the last phase, is a reconstruction of bone and the soft tissue. In our approach, we do destruction histogenesis for the bone and the soft tissue reconstruction. We will demonstrate our technique, the stage of protocol. In this case, this is a case of distal tibial fracture was managed by open reduction and plate fixation. Unluckily, the patient, there was dehiscence of the wound and the skin loss with deep infection and exposed tendon. We went for debridement, square osteotomy of the bone ends, removal of all metals and all infected tissues. We obliterated the gap by a cement spacer, closed the wound. However, there is a defect, but no problem. What's exposed is on just upon cement. The cement spacer is best enforced by kewers to avoid dislodgement of the spacer. Another important point about this column of cement is that it provides some structural stability. That's why we never apply external fixer or plate fixation in such cases. In this phase, we apply below knee cast for and allow the patient to put as much weight as he can for at least 1.5 months or 2 months. This improves the circulation, improves the bone quality, and we leave the bone virgin for any for subsequent reconstruction and fixation by external fixer. And we apply the negative pressure wound therapy over this open wound. After 6 weeks, you can see here very clean wound, and the skin defect size became smaller. We remove the cement spacer and apply external fixer Elizarov, did proximal osteotomy for transport of the bone, and this skin defect will close, or soft tissue defect will close gradually. This is after completion of the bone docking and the transport. You can see here the spontaneous closure of the skin and the soft tissue defect without any grafting. This is another case, infected nail of the tibia, previously had skin loss with deep infection, treated by rotational fasciocutaneous flap, which failed with exposure of the tibia. We did our square osteotomy and the debridement, removal of the nail, insertion of the cement spacer, and we left the patient walking in a below knee walking cast, and the cement spacer was exposed. We removed the cement spacer and then applied Elizarov external fixture. We did distal osteotomy in the longer bone segment for distal to proximal transport. Please notice here, after removal of the cement spacer, 2 months after insertion, we can see here the new bone formation. You can see here the posterior lateral aspect new bone formation here along the cement spacer. That's why we were not able to complete the transport and docking, because the newly formed bone here posteriorly, you can see here posteriorly and laterally, there is a bridge of bone which stopped the transport. There is spontaneous healing of the skin defect, complete healing, eradication of the infection, and the consolidation. Muscular or induced membrane technique in infected cases or cases of infected non-union. It's very interesting that in such cases, when you do debridement, we did square osteotomy, debridement in this case, we removed 14.5 centimeter extensive bone resection. We inserted cement spacer, the same protocol, applied negative pressure wound therapy here. After, you can see the progress of the condition. Picture number 1, at the time of presentation, badly infected fracture with the open wound. Picture 2, after insertion of the cement spacer. Picture 3, after 3 weeks of negative pressure wound therapy. You can see here in picture 1, this is a Doppler ultrasound before our debridement and the cement spacer and the negative pressure wound therapy. You can see how the circulation was compromised. After negative pressure wound therapy, we did a follow-up Doppler. You can see here the improvement of the arterial blood flow in the limb because of resolution of the infection and soft tissue edema. However, cultures taken from the fracture site, from the deep of the fracture site, you can see here in picture 1 the heavy 10,000 the count of the colony and the from the fracture site. On the right side, the picture number 2, before reconstruction and after removal of the cement spacer, we took another culture. The organism is still there, but the colony or the count of the bacterial count is much less. Another important point, you can see how the organism is almost resistant to all antibiotics. It was cellulose, and you can see it is sensitive only to the 2 antibiotics and resistant to all other antibiotics. So it does not make any sense to go for reconstruction in this case by insertion of vascularized bone graft or free bone graft. This very interesting article is published in JBGS about the induced membrane technique for infected non-union. They found a recurrence rate of deep infection in 42% of cases. And their conclusion was that muscular technique was relatively ineffective in achieving union in such cases of infected. It best suits the open fractures or fresh fractures. If you are insisting on doing the the complete muscular technique, the cement spacer and reconstruction by bone graft, in such cases, it's better or advisable to go for repeat debridement and the excision of the infected membrane, then insert a new spacer and so on until you get a clean culture, then you can go for reconstruction by the graft. So, muscular technique works well in the acute trauma, but infected non-union, you have to be very careful. In cases of acute fracture like this cases, we did debridement and negative pressure wound therapy, then square osteotomy excision of the exposed bone, cement spacer, and propeller flap. Then we will go for pedicled or vascularized fibula. In conclusion, our approach or this approach for staged reconstruction and destruction histogenesis, it is very interesting. The overall cost is much less. It avoids delayed adjuvant treatment. However, it has prolonged hospitalization. There is no donor site morbidity that provides an optimum form and function. But the downside of the destruction histogenesis and the stage reconstruction, it needs a long learning curve, tedious work and follow-up, committed surgical team, and a motivated patient. Researchers who perform limb reconstruction for traumatic composite bone and soft tissue loss need to have a universal system of evaluation and a common language of communication and technique selection criteria and outcome measurement tools. This would improve the management and the treatment of our patients. Thank you.
Thank you so much, Professor Mahmoud Elrosasy, for this very interesting talk. Thank you so much, sir. We are waiting for questions, and I will start with a question to you, Professor Mahmoud. You said that there is the infected zone and the transitional zone. What about if I find that the transitional zone is most of the diaphysis? Should I debride all of it?
As we mentioned, the osteomyelitis is a surgical condition. Without aggressive debridement, you will never get rid of infection. You are running a fine line, like oncology, doing debridement or resection of a malignant tumor. You have to resect all pathological tissues. The problem is that the more you resect, the more difficult is your reconstruction. But you have no choice other than a resection of all provisionally infected tissues.
Yes, sir. We have a question from Dr. Muzaffar. What's the best way to follow for infection control before proceeding to the next step of management?
Infection of?
What's the best way to follow for infection control before I proceed to the next step of management?
Yeah, the best to control infection is first is the removal of all, if you have unstable fixation, you have to remove all metalwork. And as a rule, and a stable infected fracture is much better than unstable infected fractures. Infection does not preclude healing. It might delay healing, but it does not prevent it. The best to control infection is the debridement, as we mentioned. If you have unstable fixation, you have to remove all metalworks. If you have bad infection cases, in my experience, I found that cement spacer, debridement and cement spacer is a very good approach.
Yes, we have another question, sir. Do you prefer negative pressure wound therapy versus standard wound therapy?
versus standard what?
Standard one therapy.
Yeah, no. The negative pressure wound therapy is very effective, and we got very good results with using the negative pressure wound therapy even after closure of the wound. We have the closed incision negative pressure wound therapy. It improves. It works by the suction or removal of the any infected translate. It stimulates the histogenesis and the new vascular formation, and promotes granulation tissue formation. So it's
Yes.
very good.
I have a question to you, sir. In distraction histogenesis, is there a prerequisite to do it? Do you do it in diabetic patients and patients with vascular compromise and impaired soft tissue? Is it allowed?
In diabetic patient, we have, this is a special category. For diabetic patient, first you have to control diabetes.
Yes.
The blood sugar should never be more than 8. The A1C hemoglobin should be ideally less than 7. Another point is that the latency period, you need to have a longer latency period. Usually you do the osteotomy and we start distraction after 5 to 7 days. In diabetic patients, it's advisable to postpone the distraction until 10 to 14 days. And you have to go at a slower rate. This is for the diabetic patients. And you have to be prepared for bad pen tract infection. Also, it's advisable to use all wires fixator to minimize as much as you can the half pin fixation. On the metaphyseal side, you can use hydroxyapatite coated pins, and you have to use a super rigid frame.
Yes. We have 3 questions also from our attendees, dear attendees. One of the questions, Dr. Muzaffar is asking about how I know the infection is controlled to go for the next step.
Yes, clinically, you will see the most important sign clinically is that you'll notice that the local inflammatory signs have subsided, and another most important point is the edema and swelling of the leg is much subsided, and the drainage also of from the wound. These are because you are dealing with an open infected fractures. In such cases, you will not need to do the ESR or CBC to make sure that there is the clearance of infection. You can see it clinically.
Do you need sometimes to take tissue biopsy, Professor Mahmoud?
Yes, ideally, you have from the deep of the wound, you have to take 5 cultures: aerobic, anaerobic, acid fast bacilli, fungus, and you have to do tissue culture.
Yes, sir. Another question from one of our attendees is asking about the difference between muscular technique and bone transport.
There is a big difference between muscular technique and the bone transport. Actually, I have an article published in International Orthopedics about combination of the 2 techniques, muscular followed by ELISA. The muscular technique, it's very interesting technique and works very well in cases of acute trauma with bone loss, because you will do your removal of the non-viable bone which have no soft tissue attachment. Then you end up with a bone defect. If you leave this defect, it will be filled with hematoma, which is a good media for infection, and will be filled with fibrous tissue, which makes for next or subsequent reconstruction very difficult. So you obliterate this dead space with a cement spacer or like a model. So the soft tissue will build a tunnel or a chamber over it around this cement spacer. Then you go back for this chamber and fill it with morcellized bone graft or vascularized bone graft, and then do internal or external fixation. But in cases of infection, the problem with the cases of infection, as we have seen in the last case, if you, after doing the removal of the cement spacer, If you took a culture, then you will find the organism is still there. Then if you did the full masculine technique and the insertion of bone graft, there will be recurrence of the infection, because actually you did not get rid of the infection. The infection is still there. If you insist on doing a masculine technique, then you have to repeat the debridement and reinsertion of a new space until you get clean culture. Otherwise, there will be recurrence of infection. To avoid this, we did the first part of the masculine to have a bone, a soft tissue chamber. So what is the benefit? Why we did not go for transport from the start? We are receiving a patient with bad infection, the leg is swollen, there is bad circulation, the osteoporotic bone, and the very important factor which we usually ignore is the psychological or psychosocial profile of the patient. The patient is frustrated for several years, searching for management of his condition. If you do your debridement, insert a cement spacer, and apply a below knee walking cast, and let the patient to go home for 2, 3, or 5 even. We left some patients. I have one interesting patient who came to us after 1 year, walking in his leg on the cement spacer. The cement spacer, in contrary to the antibiotic cement beads, is that it provides a structural stability. So the patient can put weight on it. So there is improvement of the patient's psychological profile. He can improve his social, take care of his social conditions. He can walk on his leg. This improves the circulation and the bone quality. Then when you go back for reconstruction, then you have a good condition or a bit to work on it, either for bone transport or bone grafting. And that's why we do not, in the first part of masculine technique, we do not apply external fixture, either Elizarov or monolateral. We don't insert, we don't trust the infection, and so we do not infix by plate, by internal fixation. So we rely only on the stability provided by the cement column and below knee walking cast, and let the patient to go home and come back after 6 weeks or 8 weeks for reconstruction by bone transport through the soft tissue chamber.
Yes, sir. Before we go for further questions, I see that Professor Senibes is raising his hand and he has a question. Dr. Senibes, please.
Thank you very much, Dr. Elrosasy, for the excellent talk and the interesting cases. I've read about Elizarov technique, one quote saying, infection burns within the fire of the regenerate. So how do you use this clinically to get rid of the infection? Does this apply to hematogenous infection as well?
Infection burns of the fire of regeneration. Actually, this is more theoretical of a practical statement. You have to do your debridement. As I mentioned, you can never totally eradicate infection because you do your debridement through a transition zone. So there is still a transudate. If you remember the Winnet-Orr technique, the Winnet-Orr technique was popularized in the Second World War or the First World War. They leave the wound for free open drainage. And this is the idea of the Elizarov technique in cases of infected non-union. You do your debridement and leave the wound for free drainage. But then you actually squeeze the wound. This is like the negative pressure wound therapy. The negative pressure wound therapy works by suction from outside. The distraction compression works by squeezing the infected non-union from inside. You actually squeeze the infected non-union to extrude any infected transudate, and you do improve the for sure you improve the circulation. This will improve the perfusion and healing of the soft tissue and the bone. This is the main factor in eradication of infection in the Elizarov technique. The improvement of the circulation, the debridement, the squeezing and the extrusion of the infected transudate from the infected non-union site. But relying only on the destruction histogenesis for eradication of infection without debridement, I don't think this would be is 200%.
What is the longest you have applied negative pressure wound therapy in a patient?
The
What
longest
is the
period for-
longest period you have applied in infected cases?
The negative pressure wound therapy?
Yes.
Yeah, we applied usually about 3 to 4 weeks.
Okay. But
About 3 to 4 weeks. That's enough.
Okay.
Yeah.
that's the longest you have applied?
Yeah.
Okay. Okay. Thank you.
Thank you, sir.
Thank
We have another 2 questions before the importance of this topic from Dr. Khalid Youssef. You said, sir, in some conditions, when infection with severely medical morbidity cases, it's better to operate, not to operate than to operate. What do you do in such cases? Do you leave them without management?
Like this is a statement of George Cerny in Cerny Medal classification. When you had in his classification, they divide the host type into 3 types. A host A is a healthy host, has no medical problem. You can go direct for reconstruction. Host B, he has a medical problem which can be corrected and controllable. Then you control his medical condition and go for reconstruction. If you have your host, or host type C, who has a medical problem like patient uncontrolled diabetes, he has chronic kidney disease and or on dialysis, in such cases, if you went for reconstruction, you may lose your patient. Then, in such cases, you don't leave him. You may go resort for amputation. And instead of reconstruction, you may choose for amputation rather than reconstruction.
Yes, sir. The last question from Dr. Muhammad Sultan, and I think you have answered it already, sir. He's asking about the bone cement. The bone cement spacer by itself is a foreign body, and he thinks that it increases infection. And after you remove, how do you fill it? I think you have answered this, sir. If you have any comment about this question, yes.
Yeah, the bone cement in the original musculae, he does not include antibiotics in the bone cement, but in infected cases, we like to include antibiotics. So it is antibiotic cemented for local delivery of antibiotics. Another very important point about the cement spacer in the femur, in several cases, when we inserted the cement spacer for 6 to 8 weeks, we found a new bone shell around the spacer itself. So when we remove the spacer, we had only to insert cancellous bone graft and fix the bone. Even we have seen this shell, as I demonstrated in some cases of tibia. They form a new bone shell around the cement spacer, which makes the reconstruction much easier. So it is, but if you leave the cement spacer for a long time, the cement spacer itself becomes infected. So you will end up with an infected cement spacer. So we don't leave the cement spacer for a long time. But if you had an infected cement spacer, you can remove it, do another debridement and excision of the infected membrane, and insert a new cement spacer. So it's not a big problem.
Yes. At the end, I would like to thank you, Professor Mahmoud Elrosasy, and many thanks to you. Many thanks to Professor Manoj. Many thanks to my dear friend, Dr. Cernivas, and to Ortho TV, to Eva Pharma Company. I am apologizing for all of you for the next week because we will be in the feast, Al-Adha feast. كل عام وحضراتكم جميعا بخير. So we will transfer the next presentation from its time to the last of the course, inshallah. كل عام وحضراتكم بخير. Happy Adha. Thank you so much. Many thanks, and see you after 2 weeks, inshallah. Thank you so much. Thank you so much, Dr. Cernivas. Dr. Mahmoud, شكرا جزيلا يا فندم. Thank you so much.
Thank you.
كل عام وحضراتكم بخير جميعا. Thank you so much.